Welcome back, the Hand to Shoulder Solution, giving pain the middle finger. I'm your host, Carl Petitto. I'm an occupational therapist and a board-certified hand therapist. I specialize in the rehabilitation of orthopedic conditions of the fingertips through the shoulder. Basically, anything that's causing pain, we deal with as hand therapists from the hand through the shoulder. We thoroughly examine or evaluate the condition, come up with a treatment plan, do very targeted, evidence-based treatments that are proven by research to get patients well in minimal time. So this episode, I want to discuss the wrist and hand, and I want to start with the basic anatomy and mechanics of the wrist and hand. Of course, it's all connected, the shoulder right down to the fingertips. The forearm is part of the wrist is part of the forearm, the hand is part of the wrist. So there's going to be some overlapping information, but I want to be thorough, but at the same time concise. But I really want people to understand their bodies. I want people to understand what might be causing my pain. I always want to start out with a short disclaimer and really explain that this is not treatment or advice. This is information sharing that you may be empowered to make decisions for yourself in accordance with your healthcare provider. Information is power. So I want to empower my patients. I want to empower the public to know that, hey, if something hurts, I really need to get in and be seen. And also, what is a hand surgeon? We discussed that on a previous show. What is a hand therapist? Why does that specialty exist? But for right now, let's get right into it. And let's talk about the general anatomy and biomechanics of the wrist and hand, and I think that you'll find this quite interesting. A lot of people don't realize that the wrist is made up by 15 different bones. And this is giving the middle finger to pain, so I'm going to keep the hand position that way. But if you look at the tip of the elbow, that's the ulna, and that's the little finger side of the forearm. The ulna always stays stationary when the elbow bends and straightens or flexes and extends. The thumb side is the radius. When you turn your hand palm up, and this is the right hand, the radius is parallel with the ulna. When you turn it palm down, the radius flips over the top of the ulna. And of course, that's part of the wrist. So if you look at where your wrist creases are, that area right here is just about below the heel of your palm. Now, the heel of the palm, that's the carpal tunnel, and we'll get to that. But just below the heel of your palm, you have what's called the drudge, D-R-U-J, or the distal radial ulnar joint, where that movement occurs. So you can also see, I'm sure you're also noticing that movement is also occurring at the elbow. It's the whole radius. So that's a significant connection when we're talking about the wrist. We also, in the clinic, I'm also dealing with the elbow. So when a patient comes in with the wrist pain, determining, what I can tease out and find out what is the source of the patient's pain. Sometimes it's also significantly coming from the elbow. So let's now move a little bit distal or more toward the fingers. We have 8 carpal bones. And then past these 8 carpal bones, and by the way, they all have a name. And then beyond that is the metacarpals, and the metacarpals are in your actual hand. So I taught karate for many years. We would also always punch with the first 2 knuckles. The knuckle is when the striking surface is the end of the first 2 metacarpals in the hand. Okay. Now, if you count all the bones, the radius and the ulna and the 8 carpals and the 5 metacarpals, that's 15. So there's 15 bones that assemble the wrist. There's 24 ligaments that connect all these bones. So ligaments connect bone to bone. tendons connect muscle to bone. Now the muscles in the forearm, and I happen to have a forearm with muscles on it right here. The muscles in the forearm turn to tendon about this area where it's gray, and then they insert on different areas of the wrist and the hand. So our wrist flexors and extensors and our finger flexors and extensors, most of them are in the forearm. There's some within the hand, but around the wrist, we primarily only have tendons and nerves and blood vessels and bones. So this area is easily injured, and you might be thinking to yourself, because there's 15 bones that make up the wrist, and there's 24 ligaments and 24 tendons that go through the wrist, well, there's a lot that can go wrong. And that certainly is the case. We demand a lot of our wrists. So if a person is falling and they can reach up and grab something, the wrist has to be stable enough that we can save our life with it. We also need to be able to push. We need to be able to defend ourselves. We need to be able to use heavy tools for hammering. We need to lift heavy objects, so we need that stability. With so many moving parts, it's hard to have stability, but the stability is obtained by one thing that is very interesting, is that when the ligaments that connect bone to bone, they are arranged in a way, and the muscles are also arranged in a way that put a torsion force on the carpal bones, which, by the way, make up the carpal tunnel, we'll talk about in a few minutes. So there's always tension on them, which keeps them tight. Now, we also have to be able to write, to repair a watch, to button buttons, to do fine motor things like that, to sew, to pass thread through the eye of a needle, et cetera, et cetera. So we have the big, aggressive strength items I mentioned, and we also have the fine items, which I just talked about. So the wrist has to be everything. It has to be strong and stable, and also very mobile at the same time. We can do all these motions with the wrist: flexion, extension, ulnar deviation toward the little finger, radial deviation toward the thumb, and also circumduction, and to move that wrist around. And when you move the wrist, all of these little bones move and shift on each other. So let's talk about those bones. Those are the carpal bones. So on the thumb side, we have the scaphoid bone, and that gets fractured pretty frequently. It's a commonly fractured bone when you slip and fall on an outstretched hand. Next to that is the lunate. And then there's a ligament that's often torn between the scaphoid and the lunate that connects them both together. That's a scapholunate ligament. And then we have the pisiform bone. I treat patients where a lot of patients will lean on this area or put pressure there. Massage therapists often will use this little pisiform bone to do some massage work, and the pisotriquetral ligament gets really inflamed, and that becomes problematic. We can talk about that later. The triquetrum is underneath that, and there's the hook of the hamate. See that little hook? The ulnar nerve we talked about in the last episode that goes through the cubital tunnel. When you hit your funny bone, you're actually hitting your ulnar nerve. That goes all the way down and goes through Guyon's canal, Guyon', Guyon's canal, and that's right here next to the carpal tunnel. And then we have capitate and trapezium, the base of the thumb. The base of the thumb is one of the most common places for osteoarthritis in the whole body. So of course, yeah, the weight bearing joints are really, wear out significantly, the knees and the hips, but the thumb, look at how many degrees of movement the thumb has. And we really overuse our thumb, and we'll talk about that later too when we discuss some ergonomic considerations of the wrist and hand. Now, those carpal bones, they're all assembled by ligaments, and they form sort of a C shape. If you look down on your palm and you see the heel of your palm, that's what you're looking at right here, and that's that concave section. So convex and concave, when I was younger, it always confused me. But if you look into a cave, you're looking into the hole, that's the concave, okay? If you're looking on the outside of the C, so my first name is Carl, so C-A-R-L, left to right, you're looking at convex. So convex, I picture the V like that, you're looking at the convex side on the back of the wrist. Here you're looking at the concave side, you're looking into the cave. Now, there's a ligament over the top that forms the top surface of the carpal tunnel. That's called the transverse carpal ligament, or the flexor retinaculum. That forms the roof of the tunnel. So the carpal tunnel is significant because the tendons that connect the muscles of the forearm to the fingertips, there's 2 tendons to every finger. So there's 2 muscles in the forearm. One of them is called FDS, flexor digitorum superficialis. Another one is called FDP, flexor digitorum for digits or fingers, profundus. And that one lies underneath the superficialis. So here's what happens. So the superficialis, it goes through the carpal tunnel. And remember, there's 1 to each finger, so there's 4 of these. They insert right here on the middle bone. So we just call these bones of the finger, there's 3 of them. So there's a proximal, middle, and a distal phalanx. In the clinic, we just call them P1, P2, and P3. So when we're talking to each other, they fractured P2, they fractured P3, there's a fracture at P1, so they insert on P2 right here. So that muscle is gonna bend the middle knuckle of your finger and that big knuckle of your finger. And the tendon splits into two wisps. So between that split, the tendon of the FDP goes through there and inserts on the fingertip. So when you just bend your fingertip, you're using a whole separate muscle. So, and that's another tendon that goes through the carpal tunnel. So 2 tendons to each finger, that means there's 8 tendons that go through the carpal tunnel that eventually make their way to the fingers. And that's how we can have such a tight grip. And there's also muscles between these bones in the hand called the intrinsics that also assist with closing the fingers. But we're not done. There's also a tendon which is flexor pollicis longus muscle in the forearm. And that tendon goes through the carpal tunnel. It goes to the tip of the thumb. Now, that makes 9 tendons that go through the carpal tunnel. Well, okay, great. 9 tendons go through the carpal tunnel. Why is that significant? Another structure that goes through the carpal tunnel is the median nerve. So in the cubital tunnel, in the elbow, we talked about the ulnar nerve. And all of these nerves, they're about as wide as my pen, and they're thick like a linguine, thick like a noodle. And the nerve branches out and innervates or plugs into the thumb, the index finger, the middle finger, and half of the ring finger. So when patients come in and they say, oh, it's numb and tingly here, some patients will say, and it's weird, just half of my ring finger. So it's really textbook. And I know immediately it's the median nerve. Now, it doesn't mean it's compressed at the carpal tunnel. It could be compressed further upstream. It could be at the neck. It could be the armpit region. It could be multiple areas. Now, the reason why we don't want to lean on our wrist or use our wrist like a hammer is because that nerve is pretty superficial or shallow, lives underneath the skin, underneath that ligament that I showed you forms the roof of the carpal tunnel. And pressure on the nerve kind of chokes it off, and that's why you get the numbness and tingling. When you cross your leg and your foot goes to sleep, it's not circulation, it's pressure on a nerve, okay? So it's the same thing in the carpal tunnel. Now, what happens is when we're using those tendons that we talked about that travel through the carpal tunnel, they insert on the bones of the fingers, and we're moving our hands and using them and aggravating them, and some people even will use a wrist pad in front of their keyboard and rest their carpal tunnel on their wrist pad. So now what does that do? That increases friction. So now the tendons are gliding in and out, and they're rubbing on the pad, and there's pressure, external pressure now on that carpal tunnel, friction. The tendons start to swell up. Makes sense? The tendons swell up. So if they swell up, you start taking up more space in the tunnel, and as they take up more space in the tunnel, it puts pressure on the nerve. And when you got with pressure on your nerve, when you cross your leg and your foot goes to sleep, you get numbness and tingling. And then in the fingers, you get aching and a lot of pain. So the treatment is we want to move the keyboard to the edge of the desk, get rid of the wrist pad. We want nothing but air on the carpal tunnel when you're typing, and the wrists in a pretty straight position. At night when the people are sleeping, if you're sleeping like this, that's putting pressure on the carpal tunnel. That's kind of choking off the tunnel. So you picture it, there's pressure there. Now, sleeping like this, of course, that puts pressure in there in the carpal tunnel. So a good nighttime brace would be really anything that blocks extremes of wrist flexion or wrist extension. Studies years ago, we used to think that positioning the wrist in approximately 30 degrees of wrist extension maintains the maximum diameter of the carpal tunnel. But most recent studies have shown that, about 3 degrees or 5 degrees of wrist flexion and a little bit of ulnar deviation does maintain the maximum diameter of the carpal tunnel. And why does that matter? Because, of course, we want to relieve pressure. We have to relieve pressure on the nerve. And that's what surgery is designed to do. So the surgery is called a carpal tunnel release, to release the pressure on the nerve. So what is the surgery? So if we take the carpal tunnel here and we have that ligament over the top, the surgery is to go underneath the skin and cut the ligament to relieve the pressure, okay? And that opens up the carpal tunnel. But my job as a hand therapist is to help people avoid the need for surgery, or people who have had surgery, if they're having any, challenges of inflammation and discomfort and maybe continued symptoms, we want to, get rid of that for them. Now, all of the braces that I use in the clinic, the splints, I make them custom. Patients will come in because they've been having symptoms and they want to figure it out for themselves. So they go to the store and they buy an over-the-counter brace. Most of the over-the-counter braces have a stiffener bar in the brace. So the stiffener bar in the brace lives right over the carpal tunnel. So here's a stiffener bar that I pulled out of someone's brace. I just used a pair of needle nose pliers and pulled it out of the thick, bulky nylon brace. When you're sleeping with this brace on and the brace is snug, it's putting pressure on the carpal tunnel. If they go like this or try to bend the wrist, and because the brace wraps around the whole wrist and forearm, it's going to push that carpal tunnel forward and it jams it into that stiffener bar more. So if I remove the stiffener bar, guess what? In a couple of days, they immediately start feeling better because at least the bulkiness of that thick nylon brace is blocking extremes of wrist flexion, extremes of wrist extension, but the stiffener bar is not there, so it's continuing to choke off the nerve. So these are really problematic. I could talk about that for a long time, but I'm going to stop there. So, that's some of the basic anatomy of the wrist. When you get into the hand, we have the 5 metacarpal bones, and those are the bones in the back of your hand and the palmar surface of the hand. And when you look at the hand and you see all these, the red is muscle bellies, you see the blue tendons here, you see the white ligaments. Look at that thick, heavy white ligament. The palmar arch consists of an arch there's two transverse arches, a distal and a proximal, and then there's a longitudinal arch this way. And that can be stretched and opened up. And that brings me to something I wanted to mention, that most people want to squeeze a ball for strength, a stress ball too, and it's not healthy for the hand. It makes the palmar arch tight, makes it more cupped. It affects the intrinsic muscles, which we'll talk about in a few minutes. What you want to do for strengthening is something that is more square. So a hand grip strengthener that we use in the office that we issue to people is something like this that can be squeezed down, that we can add tension to, and it could be adjusted for small hands or large hands. You can just add tension to that, and that's really, really optimal. So that can be stretched. So if we remove this, and we see the tendons that go through the carpal tunnel, and there's little loops of ligament that hold the tendons against the bone, and those are called pulleys. So as the muscles in the forearm contract and bends the fingers, the tendons have to stay against the skeleton so that way the mechanics are maintained and you don't get bowstringing. So you can imagine if the tendons weren't held against the bone, they would start to pull away like a string on a bow and arrow, right, on a bow, and you wouldn't have the best mechanical advantage. Now, where those loops are that hold the tendon against the bone, that's a friction point. So that friction point starts to cause a callus to build up on the tendon. So the callus gets big enough so that it now starts catching on those little loops that hold the tendon against the bone, and a person will, you'll open your hand and one of the fingers, most commonly the ring finger, will pop up, and that's called, you guessed it, trigger finger. So the trigger finger, if we can catch that early enough, if it's been a few weeks or sometimes even a month or two, what's really nice is, if you get into your PA, your orthopedic surgeon, and you can immediately get an injection, a steroid injection, to really stimulate the inflammation to reduce. It will help to stimulate that size of that nodule on the tendon that's catching on the pulley to decrease in size, and then immediately get into therapy. So in hand therapy, what do we do for that? Well, let's talk about inflammation. So we want to shrink that down with ice. So at home, I'll have patients hold the ice cube with a napkin or something and just glide the ice cube right on where the big knuckles bend. So it's most commonly trigger finger occurs at the A1 pulley. You can look that up. And where your crease is, this is called the distal palmar crease right here. That's where your big knuckles bend. See that crease right here? That's just a relief of skin, so the skin doesn't gather too much. But where it really bends is where the big knuckles flex, is at that distal palmar crease, that last crease in your palm. So that's where I have patients glide the ice cube right there, just barely touching the skin. Ice is hard as a rock, so I don't have patients, press in there hard, because you wouldn't want to rub a rock on it, and that would certainly increase the irritation, increase the problem. So just until it's deeply cold, 10 to 20 seconds, and lunchtime, after dinner, and before bed, and that really reduces the inflammation, helps reduce the size of the nodule. Now, imagine this. Every time that catches, pop, and patients will come in. When you have a sore in your mouth, you want to keep touching with your tongue. Is it still sore? Yep. Is it still sore? Yep. Is it still sore? Mm-hmm. Yep. Is it still sore? Yep. So here, we don't want to keep pop and snap and pop and look, it's catching. Hey, still doing it. Look at that. It's catching. See, whoa. So you want to just avoid that from catching, because every time it snaps, it's irritating the nodule more. So if it's a callus on the tendon, every time that's catching on that little loop, it's getting bigger and more irritated. So how do we stop it from catching? Well, a couple of things. So one of the really, really easy thing, a nice little trick of the trade, is just a piece of tape. I really like cloth tape because the cloth tape is firm enough to really to make a difference and to really hold it. So we just wrap it, not tight, snug maybe, around the middle knuckle. And now that blocks the finger from bending all the way. So now they can still use their hand without it catching, and that allows the nodule to reduce in size. And that's a good little trick of the trade. Then, you got to throw a joke in there with your patients. So then I tell my patients, say, hey, if anybody asks, what's with the white tape wrapped around your fingers? Oh, well, I can't forget to pick up bread and milk on my way home. And that usually is good for a pretty good laugh. Now, another thing, some cases are just really, really tough and the tape doesn't work. So I'll make a little custom brace that will be worn over the finger that will block the finger from moving all the way, and that will stop the triggering to let the nodule reduce in size. That's one design. Another design is called a RMO, relative motion orthosis. So relative to the other finger's bending, this is for the middle finger. So relative to the other fingers, one finger, the one that's triggering, is not allowed to move all the way. So it's just basically I build a ring around the fingers to stop that from happening. So one pretty cool way to see is a relative motion orthosis going to work. I'll just stick a writing utensil underneath the finger and say, okay, move your hand. Oh my goodness, no triggering. And all right, well, let's make that brace. And people would typically wear it for about 3 or 4 weeks. And then, the old saying with a brace, the second you put a patient in a brace is when you start weaning them out of it. So we don't want them immobilized very long because that causes stiffness. So now that's what they can do for themselves at home. In the clinic, excuse me, it's fabrication of the brace, educate the patient what to do at home, come back in about 2 weeks, let's reassess that. Maybe we decrease the wearing time of the brace. Maybe we make a smaller, simpler brace, or maybe from the brace we go down to taping as one big step to wean the patient. So in the clinic, we're giving the patient that clinical reasoning, we're giving them that advice. Also, we can do cold laser treatment, the red light therapy that penetrates the tissues to reduce inflammation, and again, with the goal of reducing the size of that nodule. All right, so that's trigger finger. And let's look at the rest of the hand. So we took off the palmar aponeurosis, or that just really thick ligament that helps give structure and support to the palm. Now we have a couple of things. We have a group of 3 muscles in what's called the hypothenar eminence. That's at the little finger, and that's on the little finger side of the hand. When you pinch that thick group of muscles, that's a group of 3 muscles right there. And then you have the thenar eminence. Thenar means thumb. The base of the thumb, there's a group of 3 muscles, and you can kind of grab a hold of those with your finger, and those are right here. So let's remove those. The hand is very, very complex. So there, these are, now we're getting into the intrinsic muscles of the hand. Intrinsic meaning they're inside the hand. The extrinsics, because they're outside the hand, are in the forearm. Okay, so the thenar eminence, the hypothenar eminence, and then if we take off, if we go deeper, remember those tendons we were talking about that bend your fingers? They're connected muscles in the forearm to your fingers. There's 2 to each finger, 1 to the thumb that goes through the carpal tunnel. There's muscles that only attach to the tendons. Okay, and those muscles help to bend the hand like this. Those are called the lumbricals. And there's no bony attachments to the lumbricals, which I find fascinating. They live on the tendons, and they insert on the back of the finger. And there's what's called a dorsal apparatus of nice ligamentous material that causes there's a hood basically on the backs of the fingers, and that hood helps straighten the fingers. So here the lumbricals they're bending the big knuckles and they're straightening the small knuckles, because in that position, we call that lumbrical plus position, because the lumbricals are fully activated. Now, watch this. This is this is interesting. So I get referrals from surgeons and general practitioners and physician assistants and nurse practitioners with hand pain. And no matter what the patient's been trying, just doesn't get better. It's problematic. The finger hurts. It's just weird. Orthopedic tests don't really figure it out. There's MRI and nothing is really getting to the bottom of it. The patient's been dealing with this for years, on and on and on. And most of the time, when I work with the patients to kind of tease it out and figure it out, it's tight intrinsic muscles. So back to the hypothalamic eminence, that little finger side of the hand where you can grab that ball of muscle right here. I recently had a patient who was an avid biker. She would pedal her road bike all over the place, and she got really tight in here, and also in the other muscles that put the position, the lumbricals that put the fingers in this position. When you want to stretch a muscle, you go in the opposite direction of what the muscle action is, what the muscle does. So the opposite position, of course, would be fully bent of the small fingers or flexed, and hyperextended of the big knuckle. So fully flexed of the small joints, the middle knuckle and the end knuckle of the finger, and then hyperextended of the big knuckle. And that is lengthening the lumbricals and other tissue. And then also, I came in with a soft tissue tool. Use anything really, but you could even the handle of a scissor or something, and just work that soft tissue out and restore the length of those tight muscles in there. And probably after working for a couple of weeks on that, she was 100%. And you can test that. So if the patient makes a full fist and there's all the joints are bent perfectly and the fingertips are right up in the palm, but then as you start to bring it up like that, and then the fingers come out away from the palm, tight intrinsics. So here's the stretch that the patient does at home. Starts to come up into, so, all right, this is called the hook fist position. All right. And you describe the position and you explain it to people as this and that, but I don't care if it's, a 90-year-old lady or a 10-year-old, boy. It doesn't matter who it is. Everybody understands a flat fist or a throat punch fist. Everybody understands that for some reason. Maybe I just live in a tough neighborhood. I don't know. So anyway, what you do is you get that, push it up. It's sort of like a throat punch position while you're keeping the fingertips bent right in until you feel a stretch in your fingers and or your hand. And that's the stretch. And then they're really pleasantly surprised that they're feeling much better after a couple of weeks of that. And then in the clinic, stretching the palmar arches. We're doing whole laser treatment. We're doing sometimes ultrasound. We're doing other stretches, mobilizing these bones on each other. All right, doing some traction to the fingers, pulling to relax tight musculature. Just as an aside, my brother used to ask me to pull his finger. That was different. Anyway, when you go deeper in the hand and take that off, now you can see muscles between each one of these bones, the bones at the back of your hand. Those are the interossei, the dorsal and palmar interossei. They do this and that. They bring your fingers together and they spread them apart. And that's a significant thing to consider as well. That's a significant clinical aspect. Now, there's also muscles inside that control the thumb. So the muscles in the palmar surface and the dorsal surface. So dorsal, where's dorsal? Think of a dorsal fin on a shark. It's always on the back. So the back of the forearm, but and those control the thumb, but also the muscles inside the palm control the thumb. And they do motions like this and like that and like that. So let's set that aside for a moment. And let's talk about back to the wrist. I want to show you the wrist again because it's important to remember that on the thumb side, that radius bone in the forearm, that connects to the bones of the carpal tunnel, and those are very close together. Now, on the little finger side of the wrist, there's a big space. In that space, there's not much support there. So when patients get mad and punch a door, punch a wall, they get what's called boxer's fracture, where the bones of the back of the hand on the pinky finger side fracture. Now, when I'm teaching karate, I'm always teaching you to strike with the first two knuckles. Why is that? Why do we teach that? It's because those are congruent. Those are supported by the radius, and you see how close that is here. There's a lot of stability. Over here, there's instability. If you punch with the little finger side of the hand, it's not designed for that. Now, when that fractures, it can either be stabilized with a custom-made splint that would mold onto the patient's hand, depending on where the fracture is, or mold onto the patient's forearm. And also, sometimes if the fracture is in pieces, or if it's comminuted, or if the fracture is shifted or displaced and it has to be realigned, the surgeon has to go in and they have to use their hand and realign it. Sometimes put a pin in it or plate and screws. So sometimes patients will come to me, there's wires sticking out of their hand with a ball on the end for safety. And then I'll fabricate the custom brace over the hand, taking it, working around the wires. And we get patients moving as soon as 4 days, 5 days after surgery. But it's my job to educate the patient how to safely move, how to manually stabilize their fracture site and get the uninvolved joints moving, especially this one. So this one is really interesting, the big knuckle. When you look at the side of the knuckle, it's wider. As the finger bends down, it moves over a wider surface of the end of the bone. There's the little ligaments on the side that are in their shortest position when the finger is straight, and then when the finger bends, and that big knuckle, when the finger bends, now the ligament is pulled taut. And that's how you can have another reason why we can have such a tight grip, is that when the finger is bent, now this ligament has to be pulled taut, and it's pulling that end of this finger bone right into that hand bone and really keeping it solid. Now, why is that so significant for the therapist to consider in the clinic? If that is allowed to sit there straight and that ligament on the side is in the shortest position, it's going to shrink up. And now, guess what? Now they get out of the cast or whatever they're in, and maybe they're kept straight like that for a long time. Now you try to bend it, and it's not going to bend because now that ligament is shortened up, and it is really hard to lengthen that ligament. There's no good surgery for that. There's some things that can be done, but this is where an ounce of prevention is worth 10 tons of cure. So that's why we position that joint in at least 70 degrees of flexion to maintain the length of that ligament while this bone is healing. So that's a very important thing. And then that's also why we get these moving early, 4 or 5 days after surgery. Sometimes a week or two, if it's not surgery, we get these moving as soon as this fracture site can tolerate it. So if you have that problem and you're not referred to hand therapy, you got to get into hand therapy. Now let's go back to the pinky finger side of the wrist. And remember I was talking about where that space is. So in karate, we punch with the first two knuckles. All right. Because there's that space on the pinky finger side. We punch with the first two knuckles on the thumb side. The TFC is over here. It's called the triangular fibrocartilage. If you look at this little bony point right here, that's one point of where that little triangular shaped trampoline sits. It's a shock absorbing area. So when you squeeze tight, you see that tissue gather right there. If you squeeze tight, and by the way, the power side of your grip is the little finger side of your fist. Little finger side is the power. So when you grip, your power is coming from the little finger side of your hand. The thumb side is designed for bolts, buttons, and writing, more fine motor things. This is your power. That's one of the many reasons why the small finger is one of the most important fingers. The small finger and the ring finger, very important for power. Now, there's a shock absorber. It's a triangular shaped trampoline. It's a fibrocartilage, meaning it's cartilage with fibers running through it. So what holds that fibrocartilage trampoline in place? The TFCC, the triangular fibrocartilage complex. Those are little ligaments that travel from the ulna up to different areas, okay? And those are delicate too. Sometimes they get overstretched, they get irritated, sometimes they actually get torn. That triangular shaped trampoline, the TFC, triangular fibrocartilage, that sometimes gets torn, almost like a knee meniscus. Sometimes you might get little wisps of material that are coming off that little trampoline, the TFC, and the surgeon has to go in there orthoscopically and clean that up, because those little wisps can be, kind of flopping around inside, causing a lot of ulnar-sided wrist pain. Now, some more mechanical considerations. When your hand is palmed down, remember the radius flips over the top of the ulna. So the radius flips over the top of the ulna. Now, the shortest distance to anything is a straight line. Point A to point B, the shortest distance is a straight line. So if the ulna is staying straight, but now the radius is turned this way a little bit because now it's crossed over the ulna, now the ulna is in a longer position relative to the radius. So that means the end of the ulna is pressing harder now on that trampoline, on the TFC, the triangular fibrocartilage. When it's palm up, now the radius is in a straight line. It's not crossed over the ulna. When it's palm up, the radius is absorbing the pressure through the wrist, and that TFC, that triangular fibrocartilage, that trampoline, is now not pressed on. So in the clinic, part of my exam is have the patient squeeze when they're palm up. Does that hurt on the little finger side of your wrist? No. Okay, perfect. Forearm neutral, halfway between supination and pronation, thumb side up, squeeze. Does it hurt? Yeah, a little bit. All right. Palm down all the way. Squeeze lightly. Oh, that hurts a lot. Okay, so now I'm knowing that the ulna is being pressed into that little triangular shaped trampoline, and there's a problem with either the trampoline or those little ligaments that keep the trampoline in place. All right. So that's called axial load. So the long axis of the forearm is squeezing. That's loading the axis. That's an orthopedic test. Then I want to press in here in the ulnar fovea. And is it tender upon palpation? Is it tender when I press? So the patients will actually jump. Yep, pretty tender. Okay, that's sore. So we'll do several different things. And remember earlier we're talking about differentials, or what else could it be? I want to look at the ECU tendon, extensor carpi ulnaris. There's one muscle in the back of the forearm that when it contracts, it extends the wrist or raises the wrist up toward the back of the hand. put resistance on it. I'll touch the tendon as a sore, put resistance on the muscle, feel the actual muscle belly. Are there knots in the muscle? Et cetera, et cetera. So we really have to tease it out, figure it out. So let's say it is a problem with that triangular shaped trampoline. I'll make a little gutter out of thin material and put that here on the forearm, over the wrist, over the hand, and then the fingers will be free. And that will support that area enough and allow the patient to move in a functional range of motion so they can do things. But it blocks the movement just enough to allow this area to heal a little bit, which, of course, another complicating factor is that there's not much blood flow to the area. So if you don't have much blood flow, you don't have much oxygen and nutrients going to the area. So what does that mean? That means slow healing. Now, we start weaning the patient out of the brace, and then we start adding some light strengthening. I'll do just, isometrics, really gently with maybe a little bit of low weight. Out here in this position, it could be pretty firm weight where you just hold it till you're lightly tired. And then when you're going palm down, I'll have the patient, okay, tell me when it starts to hurt. Right there, it starts to hurt. Okay, let's work just shy of that position. Now hold that position until it gets a little bit tired. As they start doing better, they start adding more weight, adding more resistance. They can go a little bit further. And then we also use another important tool is a hand grip strengthener that we can adjust the tension. So I might start with one rubber band. Okay, squeeze the palm up. Does it hurt? No. Perfect. Let's add another rubber band. Does it hurt? No. Perfect. Let's add another rubber band. Does it hurt? Yep, a little bit. Let's take that one off. 10 repetitions, 2 or 3 times a day, and that's it. Come in. Every time you come in, you're going to bring the hand grip strengthener with you. I'm going to add some more tension. Now, let's put you in a different position. Now you're in the forearm neutral. Thumb side is up. Squeeze it down. Does it hurt? No. Okay, let's add another rubber band. Does it hurt? No. Perfect. All right, do that. I'll see you next week. Bring the hand grip strengthener with you. We're also doing different things in the clinic. And then when they come in, the most provocative position, or the position that provokes the symptoms more, is a palm down position. All right, 1 rubber band, 2 rubber bands. Does it hurt? No. Perfect. Let's add another rubber band. So then we progress that patient along that continuum as we're also weaning out of the brace, and we're using other techniques also in the clinic and different techniques at home. And over a period of a couple of months, we get that to go away 100%. If the patient does need surgery, the surgeon will go in there orthoscopically. It's hard to do imaging to really determine, what exactly has to be repaired or cleaned up. Arthrogram, I think, is currently the gold standard for that. The best is always just getting eyes on it. If you make a couple little half a centimeter holes and go in with a camera, and if you find something that has to be cleaned up or repaired, then go in there with the tools arthroscopically, least invasive, and do what has to be done. And then that's a whole different ball of wax. So when the patient comes in after surgery, we treat it accordingly if the patient needs surgery. But again, remember, the idea is always, and any surgeon will tell you this as well, the idea is always to get fixed without needing surgery. So let's end this show with talking about arthritis of the hand. All right. Now, I spend most of my day when it comes to this explaining to patients what not to do. Sometimes what you don't do is more important than what you do. All right. Now, when you hit your shin on the coffee table, what do you want to do? I reach down and rub it. There's a reason for that. So when you put deep pressure on tissues, it releases chemicals that slows the pain response to the brain. And the deep pressure is very calm and soothing, like a hug. It's calming, it's soothing. But in the hand, it's bone and skin. It's bone and ligaments and tendons and skin, especially in the fingers. And if you look at somebody's fingers with significant osteoarthritis, and by the way, osteoarthritis is the arthritis from wear and tear. Rheumatoid arthritis is when your body's immune system is attacking your joints. That's a different thing. But the basic components of arthritis is inflammation and how it affects your joints. And the basic treatments is really the same regardless of the arthritis. So, all right, so let's go back to what you don't do. with arthritis. Patients will come in and it's sore, right? So while you're squeezing and rubbing it, and they'll sit there and they're sitting in front of me. I'm just meeting the person and they're sitting there and they're rubbing their hands. Now, that will decrease the discomfort while the hand is being rubbed. But when you stop, now there's a big inflammatory response. And then what does a person naturally remember? Felt great when I was rubbing my hand, so they go back to rubbing it. And it's this vicious loop. And they'll just continuously rub and rub their hand. And when they're all done rubbing their hand, they rub it some more. And that just really aggravates the living heck out of it. So when I have them break that habit, they start to feel better. But then another thing, it's arthritis. Itis means inflammation again. So when the joints are inflamed, the joints will feel very tight because of the inflammation is taking up space. So your fingers will feel so tight that people naturally just want to keep them moving. So I'll see people sit there in front of me and rub their hands, but then they'll take a break from rubbing and then just move the hands. And I'll ask them, how often do you move your hands? And they'll very proudly say, oh, I keep them moving all day. I move them anytime I think of it. So I'll bring to their attention that probably that by the end of the day, they get, a couple of thousand repetitions. If I did that with my hands, and thank goodness I don't have arthritis affecting my hands right now, I would be really sore. Take anybody and have them move their hands all day, you're going to have some really sore joints. Now, what's the name of the game? We got to get the inflammation to decrease. So stopping aggravating it by rubbing it, stopping frequent, constant, continuous motion. Now, let's go back to cryotherapy. Cryo means cold. So cold therapy. Ice pack doesn't really do it. Frozen bag of peas that conforms to the hand, that works pretty good. But what's really wonderful is a couple of, actually 3 techniques. So the first one is putting it under cold running water from your fingertips, whatever area is affecting you. So let's talk about the fingers and the base of the thumb. I would just put that under the cold running faucet, the water come right down on it, only till it's deeply cold, depending on your water temperature, 10 to 20, maybe 30 seconds. And then when it's deeply cold, I always tell patients, it's like in the summer after a long winter and all of a sudden it's 80 degrees out and you say, I want to go in that lake and swim. And you start walking into the water and your ankles start to ache because the water is so darn cold. That's deeply cold. So you take it out, you might let it warm up for a minute, just lay your hand on it. Don't rub it, of course. Lay your hand on it, warms up a little bit. Do it one more time. Another great technique is just to keep a Tupperware or something in the fridge that's full of water or an old pitcher, and take it out and stick your wrist and hand in it and out of the refrigerator. When it's deeply cold, you're done. Another option is to freeze a Dixie cup full of water and just pop the cup off, or if it's a paper one, just peel it off down so you can hold the paper cup and just lightly glide the ice. This is a little more time consuming. You glide the ice over the fingers and where the pain is until it's deeply cold. You can increase circulation, which brings more blood and nutrients to the joints by using low heat in the morning. Why the morning? Because all day long when you're sleeping, when people are sleeping, the inflammation is going down. You're not moving it and using it during the day. In the morning, your inflammation is to be at its lowest point. Side effect of heat, because heat expands, is increased inflammation. So you can put the electric heating pad, on the lowest setting on the thermostat for 10 or 15 minutes, not longer than 15 minutes, in the morning only. So you get up in the morning and, if you enjoy a cup of coffee, get your coffee and then wrap the heating pad around the hand. I explain to my patients for 10 or 15 minutes, but you can't live in the heating pad. If you do it more than 15 minutes, you're overdosing on the heat, and it will increase, it'll start to expand your inflammation. Another thing in the morning, because your patients' fingers have been resting all night, they'll get up and it'll be really, really tight. So they'll say, yeah, the morning it's really tight. I got to get it moving and start forcing it. Well, if you force it, it's really going to ramp up that inflammation, because now you're just aggravating, you're forcing, you're beating it up. I ask my people to just let it wake up naturally in the morning, with using your hand to move things and get things ready, make your coffee, use the heating pad, or if you take your shower in the morning, the warm water will loosen it up, but just use the normal shower temperature, not anything excessive. Some people will take it upon themselves to, well, if I can do that, let's just put the hot water on in the sink. That's a little too aggressive. It doesn't work very well. The ideal thing is a low heating pad in the AM only. There's another object that is really wonderful, which I want to show you, that is heat, but also is red light. So red light really increases nicely blood flow, and primarily is used to decrease inflammation. So they make these mitts. And by the way, all these things that I talk about, I'll put links to them at the bottom of the screen, so you can click on these things and find them. You just put your hand inside this mitt first thing in the morning, and that I use it because I do have arthritis that affects me on the base of my thumb, and we'll talk about that area. That's a special area. And this stays on for about 15 minutes. It's a nice low steady heat, and you get the benefit of the red light to stimulate the cells to produce nice ATP, healing chemical, and decreases inflammation at the same time. Okay, and that's the red light therapy. They also make a nice wide one, one that I like to use on my elbow, on my shoulder when I need it. This is really handy. I bought one for my grandmother to put on her knee. So I'll put links to those below. All right, there's a lot of information. I recommend that you listen to this podcast a couple of times. Write in with any questions that you might have. I like to end every show with a dedication. I dedicate this to Jesus, who continuously guides me to do right, to do well, and to continuously improve. And also to my wonderful wife, who continuously encourages me to follow my dreams. And my wonderful family, my teachers, and the community who raised me and taught me my values. Also my professional mentors who were and are patient with me and continue to answer my questions and empower me to help others to my greatest potential. So thank you for watching. More to come.